and that car can get hit from behind. And despite experiencing the exact same mechanism of event, those two people can take very different pathways afterwards. So these are the kinds of things that started driving my thoughts. And certainly started from a well-recognized model, the fear avoidance model from Stephen Linton and Johan Vleien. And I suspect many of you have probably seen this, suggesting that the genesis of chronic pain starts at the injury. We experience pain, and then we can take one of sort of two different directions, right? We can have no fear, we can confront the problem and recover, or we can catastrophize about the injury, and we can go through fear avoidance, hypervigilance, disuse, disability, that sort of thing. This model, with certainly nothing but respect, really drove a lot of pain research forward. Right? When this was proposed sort of around the late 90s, early 2000s, this allowed us to ask some really interesting questions, and certainly the field of sort of, we'll say, psychological drivers of pain has really progressed as a result. But for anyone here who might call themselves, let's say, a physical therapist, for example, you're probably noticing that there's actually no really physical aspect of this, with the possible exception of disuse eventually. That the model basically says that chronic pain is driven through maladaptive cognitions, right? And I think it's time, and I don't think this is overly contentious, it's probably time that we sort of build upon this. You know, other things that it doesn't do is it doesn't consider who the person was prior to the injury, places the genesis of chronic pain fully within the injured person, doesn't really consider the social contexts within which the injury occurs. And there's really no room here for biological drivers. I guess the other thing I'll say is there's no clear definition of recovery, and we might get to that another time. Now, far be it from me to say, hey, I've got a better idea, but we tried to have come up with a better idea. So this is a model that my friend Jim and I published a couple of years ago. And what we did here is we sort of took the same general thing where we said there's a traumatic event, and you can follow sort of one of two different pathways. One has this sort of transient and adaptive stress response. And what that means is we should all experience a little bit of distress, right? If we've been injured, whatever, we should all experience. If you're completely flat, if you have no affective reaction at all, I'm equally bothered, right? So we should all experience a bit of an adaptive stress reaction to an injury. Hopefully we draw upon our own personal resiliencies, our adaptabilities, and ultimately we can do something which I've actually called resume a satisfactory life trajectory, rather than the term recovery. On the other hand, we might take this sort of expanded, complexified version of the vicious cycle here that really starts mostly with this dysregulated stress response, and that's kind of what I'm going to talk about today. You'll see other aspects here, sense of victimization, threat, anger, that kind of thing. The other thing we did with this model, you're welcome to, I'm not going to walk you all the way through it, but the other thing we did with this model is we added in these things we've called diatheses, and we actually borrowed that from an earlier model from Dennis Turk, a stress diathesis model. And what we said is that, again, we recognize that everybody approaches trauma, encounters trauma with certain types of vulnerabilities and certain protective factors. And in fact, those vulnerabilities and protective factors are probably different depending on the context of the injury, that in one context, a certain piece of ourselves might be protective, and others, it might be a vulnerability. And I think of, for example, some of the refugees we've had coming from overseas into Canada, and I know into the US here as well, you know, people who have gone through just terrible experiences, and yet somehow some people come out stronger for it, and others are broken people. So it's not even just necessarily we can point to the event itself, but there's something about the person. So what I'm going to do today is I'm going to sort of focus more on this idea of the stress response, because I think it fits with what we're talking about here, and then give you a bit of a clue as to how we're trying to better understand who these people were prior to their injury before they come in to see us. So let me go back to these are, again, our trajectories. This is a project we've finished recently called the SIM Biome Project. It's an acronym, Systematic Merging of Biology, Mental Health, and Environment. And one of the questions we might want to ask then is, what's happening shortly after these people were injured? Now, for context with this study, both we in Canada and my colleague in Chicago had research assistants sitting in the emergency departments and waited for people to come in through the doors who had just been injured, as long as it was non-catastrophic, so as long as they didn't require surgery or hospitalization. After the medical team discharged them, and literally as they were heading for the exit of the hospital, my RA goes whoop, and tries to intercept them. And right there within the hospital, so it could have been within hours to up to 3 weeks, we asked them how much pain they were in, how distressed they were experienced, or how much distress they were experiencing, and we took some blood and some saliva from them right there. And then we sent them home with a much bigger package of questions, questionnaires. It's amazing how much people will do when they're getting paid for it. So they fill out all sorts of questionnaires, gave us additional samples of saliva. We wanted to get the cortisol waking response, if anyone's familiar with that. This is the spike in your cortisol from the minute you wake up to about 30 minutes later. Your cortisol kind of spikes like this, and then it dwindles off over there. So we wanted to know what that waking response looked like. For those who were keen, we took some of their hair, and we also got stool samples. And I will say that as a physiotherapist, that is not a world I ever thought I'd be inhabiting. I had, for like months, a freezer full of human poo in my lab. And I just went in every Monday morning hoping there was not a power outage over the weekend. I got to share this story with you. It has nothing to do with what I was about to talk about, but I think this is hilarious. When I'm working with the group that I do who does the stool analyses, they said, we've had people, one guy brought in a shoebox with elastic band around it for his sample, and they were like, we're not touching that, man. That's not what we're looking for. You never know what you might get. But I'll explain to you why. Why am I looking at this in a minute? So back to the story. I know, crazy. So back to the story. The question is, what can we figure out about who these people were or what's happening shortly after their injury? So the first thing, of course, as you always do, as a graduate student, everyone knows you do a systematic review. That's always a great way to start your thesis. And so my very first systematic review, this was actually an update of it, was doing this sort of meta-analysis of all the potential risk factors following, in this case, whiplash. And these were risk factors for chronic pain or poor recovery. And I just want to quickly highlight things here. We've got on this side of the table, those things that we had high confidence were in fact risk factors for the later genesis of, I'm going to say, no, let me take that back, for continuing to report pain 6 to 12 months later. I almost said the genesis of chronic pain. That's dangerous. Continuing to report pain 6 to 12 months later. And you can see things here. It's high pain intensity, high neck-related disability, post-traumatic stress symptoms, catastrophizing. For some reason, cold hypersensitivity in this group. We're not sure what that means, but it keeps coming up. And mechanical hypersensitivity, in particular, when we test pressure pain detection thresholds in people with whiplash injuries, we test it both over the upper traps and over tibialis anterior as sort of a distal control area. And as it turns out, those who, for whatever reason, are sensitive distally, which we think might be an indication of sort of some kind of a central nociplastic process, these people earn membership to the higher risk category. If you look over on the side of the table where we're pretty confident these things do not predict outcomes, most of them have to do with parameters of the event itself. And this paper is getting a little bit long in the tooth, so I just went and found an updated one. This was done in 2017. But once again, you can see pretty well the same results, right? So again, high post-injury pain, disability, whiplash, and cold hyperalgesia, anxiety, catastrophizing. And this group also found compensation and legal factors. Similarly, they found no association with a variety of things, including imaging findings and, again, collision findings, collision factors. And actually, we just recently published a paper in PLOS One last year where we had engineers go out to the crash, and one thing they could do is they can stick a little USB in the black box in your car. I don't know if you guys all know you have a little event data recorder in your car, as long as your car has an airbag. And from that, we can take, at the time of impact, how depressed the accelerator was versus the brake, the angle of impact, the direction of impact. You can take this from this little black box. So we could actually get quantifiable metrics off of that. They also took photos from all angles. We got damage estimates. And long story short, none of it had any association with clinical presentation.
That was super fun. I'm a pelvic health therapist. I love pee and poop.
Oh, isn't it the greatest?
So great. Well, it's essential, first of all, but also like that you can learn from it.
It turns out you can learn a lot. It took me a while to get my head around that.
Right. Okay. Well, then I'll take actually Bramjam's question first. What did you find in people's poop in relation to recovery?
Yeah.
I like that you qualified.
Nothing yet. I was hoping to have the analyses done before we got here today. We have the data. It's sitting on the computer back in the lab. The student who was meant to be exploring that is currently trying to madly finish his thesis, so we haven't yet analyzed it. Sorry.
Awesome.
If I come back next year, there will be, if you really want to know about the poop thing, it'll be available. Yeah, okay.
Awesome. Okay, so we actually have two things from Stephanie. One is awesome reference to Tim Hortons.
Thank you. Where's
And then-
Stephanie? There she is.
Then
Atta girl.
also, how might biomarkers in hair be impacted by folks who bleach and or color their hair?
Yeah, apparently not at all. Not at all. Yeah, good. I had the exact same question, and apparently the answer is not at all. Yeah. In fact, they've been able to assay cortisol from the hair of mummies, Egyptian mummies. So it sticks around. It's pretty robust. Yeah.
Were mummies stressed?
I don't know. All I know is they can do it.
Okay, then from Joe Hanley. From a clinical perspective, is there concern that classifying someone as high risk of non-recovery, do we create a sort of self-fulfilling prophecy by the way the clinician approaches the patient treatment?
Absolutely. Oh, I'm so glad. I'm glad that question came up. I kind of tried to prime that question. And I would actually, I think this is a great opportunity to have a discussion. I know this isn't the greatest forum for open discussion, but I really think that would work. That's a really interesting question, an important question we need to ask ourselves. It seems to me that there is a group of people out there who want to know their genetic risk of all sorts of things, for example. And there are a group of people who don't. And if just, the ubiquity of 23andMe and Ancestry DNA and whatever tells us that some people want to spit in tubes and send it off and get a sense of whatever their genetics are like. And they might want to know, through doing so, whether they're at risk for any number of chronic health conditions. And others don't want to know. And I think there's something really interesting in that might help us answer this question. I don't think there's a blanket statement I can offer here. If I was at risk of, I often want to know what my prognosis is. So if I was at risk, I don't know, of cancer, I might want to know that. Other people might not want to know that. If I got injured and I want to know, what's the likelihood I'm going to recover? If I'm asking that question, clearly I want to know. Now, does it become a self-fulfilling prophecy is a critical question here. I will say that in the studies we've done so far, because we didn't know, when we collected these data, we didn't know which of those things were going to predict outcome. None of the patients in our studies knew if they were going to recover or weren't going to recover, and some of them still did not recover. So I don't think that was a mechanism in this study. Could it be a mechanism clinically? Possibly. Makes complete sense. And I think that's why I put that question up earlier. How do we communicate risk? I think that's a question that we all need to think about. An approach might be something like, Mr. Jones, based on everything you've told me today and the things we've looked at and the signs I've seen, if half of people are going to follow a trajectory that looks like this and half of people are going to follow this, I think without appropriate intervention, there's a chance you might follow this one. But, and that's where I think we really need to be cautious here because there's not a lot of evidence we can lean on here, more clinical intuition than anything. But if we intervene properly and we hit the right targets, we should be able to get you back down onto this trajectory. I think that's, as of right now, that's the best way I can kind of get at that. But certainly the conversation around communicating risk, that's why I'm serious, actually. With great power, great responsibility here, we need to be cautious in how we use that.
Okay, and we have time for one more. Put it up there. From Mark Broberg, great talk. Curious if one is stressed enough due to trauma, are they possibly biased towards interpreting childhood events as more adverse?
Yeah, super great question. These are the kinds of things that sort of flow through my heads at night as well. Keep in mind, again, we're asking people to self-disclose childhood traumatic events. What we don't know is how many people are either not disclosing or have repressed those experiences. These people are 18 or older. Our average age was 40. And we're asking them about experiences prior to the age of 12. Now, if they're traumatic enough, people may well remember them. Interestingly, our study, as well as the big ACE study, I don't know if you guys know, the NIH in connection with Kaiser Permanente has been running an ACE study for years. We continue to consistently find about 60% of our sample do endorse at least one adverse childhood experience. 60%. Statistically, that's great. Socially, that's a travesty. So it's conceivable that people are underreporting. I would hope not. We're already at 60%. In this case, I think the question is asking, could people be over-reporting? And that's also entirely possible. I have no way to know how to check that. I don't know who would choose to lie on forms like that, but I'm sure there are some people who do. The simple answer is I don't know, but I think it's a good question, and just keeping in mind that we are necessarily reliant on recall and willingness to report at this stage. Incidentally, we just got funding for a 20-year longitudinal study, which will see me to the end of my career, starting with painful procedures in childhood and following these people up until adulthood. So maybe in a sort of longitudinal trial like that, like kind of a mini Framingham study, we might see something emerge there. But as of right now, we're stuck with recall.
Oh, congrats on the 20-year study.
Oh, yeah. We'll finish it, and then I'll retire.
Sounds like a plan.
Yep.
Okay, well, thank you so much. That was wonderful.
Super. Thank you.
Alrighty, so now is your chance to go get your book signed. And then also, if you can just be back here at 4:35 for our final panel, it is sure to be amazing. So don't miss it.
Cry for you.